Okay, good afternoon, everybody. And first, I want to thank the organizers for inviting me to present this afternoon. The title of my presentation is Oral Biofilms and Novel Methods to Control the Pathogenesis. So today, I'm going to focus in on a specific individual, a specific patient, and that is the edentulous patient. And I'd like to focus a little bit in terms of the overall global distribution of edentulous patients, the age distribution, and then really the bulk of my presentation is going to focus in on the activities in my laboratory that really focus in on chemical and biological approaches for affecting the biofilms which cause disease in these individuals. We all know that the age distribution of the world population has been shifting significantly over the past couple of years. Just going back not that long ago, in 1998, 390 million people globally were above the age of 65. Very shortly in 2025, the projection is that this number is going to grow. There are going to be 780 million people above the age of 65 worldwide, and there's a tremendous increase in the developing countries. If we look back in the year 2000, the overall percentage of individuals above the age of 65 was 6%. And if you look at it on a per continent basis, one can see that in Europe it was 15%, North America 13%, South America and Asia coming in at 6%. Fast forwarding to 2030, the overall population above 65 years jumps to 12%, and Europe comes in at 24%, North America at 20%, Asia at 12%, and South America at 11%. So the corollary of growing older is that there's going to be an eventual loss of teeth. Historically, we've always visualized the denture wearer through their dentures. And many of you can have that vision of your grandparents adjacent to their bed, where they basically soak their dentures during the night. But as a community, we need to shift the focus from the denture to the denture wearer. How can we make a difference in the overall quality of life and health of the denture wearers? When we look at the prevalence of edentulism around the world, it varies greatly from Hong Kong and India at about the low percentages, 12 to 15%, to a region of Brazil up at 63%. So the prevalence of edentulism continues to be very, very high on a worldwide basis. Importantly, as we start to focus in on the underpinnings of the disease that is caused by the biofilms in these individuals, we can see that the denture wearer is at risk for the development of several comorbid conditions. I'm listing over here asthma, arthritis, cancer, and even diabetes. Interestingly, there is an almost linear relationship between the number of teeth and the 7-year mortality of individuals above the age of 70. So this afternoon, we're really going to focus in on understanding the biofilms and how the biofilms contribute to two diseases, one being stomatitis, the inflammation in the oral cavity of the denture wearers, and the other one being respiratory illness. And in particularly, I'm going to be focusing in on chronic obstructive pulmonary disease, COPD. Where does it all start from? Where do these biofilms start from? So we initially looked at the interface of dental materials and the potential of microbes binding to these dental materials. And what you can see on the slide on the left-hand side, a very smooth piece of dental acrylic material has very few bacteria binding to it. And here we're looking at Strep oralis. In contrast, if you look at the panel on the right-hand side, which the material is much more rough, there you can see that there's bacterial adhesion. The Strep oralis is binding to the acrylic material. Clearly, the roughness sort of functions as a magnet for bacteria binding to the surface of these dental materials. And indeed, when we used scanning electron microscopy, one can see that there are complex biofilms on the surface of dentures. These are used dentures, and you have a variety of different microorganisms over here. The P's correspond to the pores. We know that dentures are porous, but you can see many, many different types of organisms that comprise the oral biofilms. And indeed, we did an analysis of what microbes are present on the surface of dentures, and we believe this to be one of the most comprehensive analyses of the denture microbiota. And what you can see is that there are several opportunistic pathogens, anaerobes, and yeasts. And for our purposes, as we move on forward in this discussion, most importantly for stomatitis, we're going to be looking at the biofilms of Candida albicans on the right-hand side. And for COPD, chronic obstructive pulmonary disease, we're going to be looking at Pseudomonas aeruginosa and Haemophilus influenza. So we know that a very large percentage of denture wearers suffer from denture stomatitis. Denture stomatitis is inflammation in the oral cavity. Of the 65%, many of those individuals are asymptomatic. If you want to visualize clinically what these individuals look like, so based upon Newton scoring, I'm showing you over here a healthy individual in the top panel, a type 1 Newton class individual in the middle panel, and on the bottom panel, you can see a type 2. Clearly, on the bottom panel, one can observe the redness. That redness corresponds to pain. So somehow we have to do something in order to ameliorate the pain of these individuals. But why is Candida albicans so important to the denture wearer? We know from experiments that we've done in our laboratory that there is specificity for the binding of the Candida albicans to different dental materials. When one contrasts and compares hydroxyapatite to denture acrylic, you can see a significant increase in the relative biomass of C. albicans biofilms binding to the surface of the denture acrylic in contrast to hydroxyapatite. So how do we actually deal with this, and how can we contain the C. albicans biofilms on the surface of dentures? So we actually looked at a number of different cleansers that are out there. The control is PBS. So there is no chemical material in the PBS, it's just the buffer. We looked at a variety of different dental materials, denture cleansers that are shown on the bottom portion of this graph. And one can see that if you look at Corega, which is Polident, Colgate, and some specific cleansers that have come out of China, the best performing one is the Corega, the Polident, which is manufactured and distributed by GlaxoSmithKline. Even Colgate leaves a significant amount of the Candida albicans on the surface of these dentures. Now, when we look to chronic obstructive pulmonary disease, this is of significant medical importance. Unfortunately, we are all aware of the significant killers of people worldwide. Cancer, heart disease are number 1 and 2 worldwide. But COPD has now moved into the #3 position as killing people worldwide. From the work of Tim Murphy in SUNY in Buffalo in the US, we know that some of the microbes, Pseudomonas aeruginosa, Haemophilus influenza, and Moraxella catarrhalis, contribute to the exacerbation of COPD. People have a baseline COPD level that is caused by different kinds of pollutants. But the transition to a more severe stage of disease is caused by microbial infection, the 3 microbes that I just mentioned. And thus, there needs to be an approach to prevent respiratory tract infections. And the need has to be to mitigate these exacerbations. Can we contain the disease and not allow it to transition to a more severe COPD gold-based disease system? So our approach has been, #1, to evaluate current chemical methodologies, and #2, which I'm going to share with you this afternoon, are a combination of innovative chemical and biological interventions for the specific microbes that are implicated in COPD, namely Pseudomonas aeruginosa, Haemophilus influenza, and Moraxella catarrhalis. So here you can see where we look at those 3 microbes and we treat them with chemical cleansers. We can see that you have a very good shift, a good log kill with Pseudomonas aeruginosa. The control is in gray, and the experimental, the chemical treated ones, are in green. And you can see in all cases, there's probably a 10 to the 3rd kill of the Pseudomonas aeruginosa biofilms, the Haemophilus influenza biofilms, and the Moraxella catarrhalis. So that looks encouraging. But I'd like you to pay attention to the green bars. And that is, even though we're having a 10 to the 3rd kill, there is a significant amount of material that is still left behind. Look at the green bar positions over here. The implication is that the material is left behind, and it doesn't take long for these microbes to start growing again on the surface of the dentures. Similarly, we looked at clinical specimens. So clinical specimens of Pseudomonas aeruginosa, and here you can see that in the light blue before treatment, the dark blue, the navy after treatment, again, a significant reduction in the Pseudomonas aeruginosa biofilms resulting from the chemical treatment. That said, the dark blue continues to remain on the surface. This is an indication that we do not kill all the biofilm. So let's step back for a second. And how do biofilms develop? Well, we all know that bacteria exist in planktonic format, individual cells that move around throughout any kind of individual. When they find a substrate, they bind to it, and then they start to form a nascent biofilm, a mature biofilm, and as part of the developmental cycle, eventually they disperse off and they go to other regions within the body. This mechanism of biofilm development is actually analogous, unfortunately, to how cancers develop and metastasize. So we looked at using the conventional chemical cleansers. We looked at the biofilm production of Candida albicans. And here one can see that there's a significant amount of biofilm that's produced in panel A. But if you look at the cell release in the biofilm life cycle, one can see that the ZK bars correspond to clinical samples, and those samples actually release more cells as compared to a laboratory strain, which is the SC strain. Interestingly enough, when they're treated ahead of time with the conventional chemical cleansers, one can see a total shift. And that is a very significant reduction in the release of cells and cell dispersion in the clinical samples, in all cases greater than a 90% reduction for the ZK clinical samples, and the laboratory sample was approximately 70% reduction. This is significant in terms of the reduction of the cell dispersion coming out of the biofilms. Now, as I told you in the last couple of minutes, when you focus in on the kill, which was pretty good using these conventional chemical cleansers, nevertheless, the point that I want to make is that the chemical approach, the conventional chemical approach that's available today, fails to remove the biofilms completely. Thus, there is a need to develop innovation to combat these oral biofilms. So from the chemical approach, we are working on selective microbial colonization. One has to submit that these microbes are here. It is actually wrong to try to come up with a strategy that you're going to eradicate the microbes, because each and every one of us is not a human being. 90% of us are bacterial cells. So it makes no sense to try to come up to an approach of where we're going to kill the microbes. The approach that we try to use in our laboratory is to come up with selective microbial colonization. Can we replace the pathogenic microorganisms with the healthy commensal microorganisms? And this is just a schematic in terms of trying to remove the pathogenics off the surface of the denture and replace them with commensal, and therefore you maintain homeostasis. So I'm going to share with you 4 different formulas that we've worked on. One is in terms of going back to the roughness of the denture material. Can we actually retrofit it subsequently and smooth out the material? Point number 1. Number 2, can we have a transient coating to shift the population of microbes from pathogens to commensal? And number 3, can we come up with a permanent coating? So here in formulation 1, the scratch surface, the native surface, is shown on the left-hand side. The coated surface that has been treated is on the right-hand side. It is smooth. When we move to the temporary application where we use cross-linked materials with antimicrobial agents, what you can see is that in terms of the pathogens, Candida and Fusobacterium, look at the difference between the uncoated samples and the coated samples. We basically have knocked down the pathogens. Look at these bars on the coated samples and recall what the bars looked like in the chemical treated samples conventionally before. In contrast, a commensal microorganism, Streptococcus, you can see that the coated material promotes the growth of the organism on the surface. So one can shift from a pathogenic state to a commensal state. The third approach is using a permanent surface modification to the denture surface. And here with this formula, formula number 3, once again, you can see that the Candida and the Fusobacterium were knocked down significantly with the active coating. Just a little bit of material is left behind, but the Streptococcus was actually increased in terms of the growth. That is the strategy for the novel chemical innovation that we're using in the laboratory, from shifting from pathogenic to a commensal state. The next innovation, and the last innovation I'm going to share with you, is a biological approach. And here we facilitate microbial dysbiosis. Many of you are aware of in terms of fecal microbiota transplants that are used in the GI patients, where basically it is known now that if you change the distribution of the microbes, you can transition from a unhealthy GI system to a healthy system. And so here we show you with Pseudomonas aeruginosa, when the biofilms were treated with probiotic organisms, proprietary organisms that we have in the laboratory, there was a significant reduction in the biofilms. And this is basically a dose-dependent formulation, which you can see on the x-axis, going from 100 liters to 300 microliters of the probiotic. This is important because if you can disrupt the biofilm, you can then treat it with antibiotics. Conventional biofilms are impervious to antibiotics. Very interestingly, we've isolated a probiotic microorganism and assayed it with a minimal inhibitory concentration assay, a membrane disc assay in the laboratory, and looking at its effect on Haemophilus influenza, which is a key component in exacerbation of COPD. And apparently we've discovered that there is something that is being secreted outside from these probiotic microorganisms that kills Haemophilus influenza. So this happens to be a natural approach, both in terms of the Pseudomonas aeruginosa disruption of the oral biofilms, as well as in terms of killing the Haemophilus influenza with a probiotic, a commensal microorganisms. So the technical innovations that we shared with you this afternoon are one, the chemical, where we shift the balance from pathogenic to commensals, as well as the biological approach, which disrupts biofilms and, more importantly, can actually kill the pathogens. And so, in conclusion, we know that oral and systemic health is a complex phenomena that which goes on in the oral cavity. The oral cavity, the mouth, is the portal into our overall system. From people that have intact dentition, we know that periodontal disease contributes to a number of systemic diseases: cardiovascular, stroke, renal, and certain kinds of respiratory disease. This afternoon, I focused in on a different population, the edentulous individual, that individual that has lost some of their teeth and replaced it with a denture. And clearly we can see the implication from our discussion this afternoon in terms of respiratory disease, but what other systemic diseases can be aided by eradicating the pathogenic oral biofilms. In summary, the age distribution of the world population is changing, and that is good. People are living for a longer period of time. I shared with you that the respiratory pathogens contribute to COPD exacerbation. Conventional approaches do not really deliver. Too much material remains on the surface of these dentures, and hence we've had to come up with novel approaches, both in terms of chemical approaches as well as biological approaches, for eradicating the pathogens in the oral cavity. I'd like to stop by acknowledging my collaborators, Dr. Wen Shi from Harvard University, Dr. Ben Wu from UCLA, Dr. Deborah Hogan from Dartmouth, Professors Aaron Moment and Helen Liu from Columbia, and my students at Truro College University System, Daniela Berger, Aviva Rakimova, and Rebecca Emirzada, and my technician, Calvin Wang. I thank you for listening to my presentation, and I wish you all a very enjoyable conference.